I've got about four minutes after, and we don't want to take up all of your day, Che, but we certainly welcome Deputy Chief Che Steadman today to the program. One of the things that we discussed last year in our planning, and of course in the fall now, this is to look at what's happened with mental health issues in the cities around the country. We know that we have examples of Cahoots up in Eugene, Kurt's family up there. They've been around for about 30 years. Sounds like doing some of this. And the CARES program is new, I think, a couple of years now, and maybe it's a good time to find out what it is, how it works, and why you're in charge of it. But first, you can start off by telling us a little bit about who you are, because I don't think we know a lot about police officers and deputies. We don't hear a lot about fire department folks.
Yeah, certainly. So, hi, everybody. My name's Che Steadman. I'm one of 4 assistant chiefs with the Madison Fire Department. All 4 of us have areas that we oversee, and I oversee the medical affairs with the fire department. So anything to do with our EMTs or paramedics training, operations, and you name it. And over the last 5 years, we've also been using a community paramedic model, which I'm going to get into here in a second, which is kind of where we started with providing services in the community in a non-911 situation, going out and helping folks that need services outside of 911. And I'm going to talk primarily today about our crisis response team, or the CARES team, but I'm going to share a few slides about our community paramedics as well. But I've been on the department for about 27 years, started out as a firefighter paramedic, and have worked on our special teams. So we have a hazardous materials rescue team, we have a lake rescue dive team, and then we have a heavy urban rescue team, which is like building collapse and high angle rescue, confined space rescue. So, fire departments and police departments do a lot of things outside of what I think the public typically expects of us. And, for the last couple of decades, the police department has always been expected to respond to behavioral health crisis. And so looking at models around the country, we found that there is alternate ways for these behavioral health crises to be addressed. And so the fire department is now responding with a paramedic and a crisis worker from Journey Mental Health. So I don't have a lot of experience in mental health provision, but just by happenstance, I happened to go to grad school here at the UW Madison on the 9/11 GI Bill for rehabilitation psychology. So having a master's degree in kind of the counseling area certainly helps me in this role, but I don't have a lot of experience, and that's why it's really imperative that we work with our local mental health providers in these sort of programs. So I'm going to go ahead and share my screen. And I've got a few slides to talk through about our community paramedic services. And then I'll get into the crisis response team just to want to make sure everybody can see my slides. Good. Excellent. So one thing that we started doing in 2015 was called just simple kind of patient referrals, where people had low acuity chronic conditions that they were calling 911 for very often, and not just using up 911 services, but also obviously going to ERs where they didn't really need to be. And so this is a lot of social work type stuff. We work with case managers at the hospitals to go out and visit people in the community after we notice that they've been using 911 services a lot, and provide them healthcare system education, medication reconciliation services, basically anything they need outside of 911 to refer them to the appropriate social services, or sign them up for Badger Care, or help them through the Affordable Care Act, whatever it is they need to help them use the healthcare system in a more appropriate way, which not only reduces stress on the 911 system and the hospital system, but it's better for the patient themselves. And so in 2021, we had over 150 of these patient referrals where we were able to go out and help folks in the community outside of just a 911 call. And this is probably a hard screen to read, and I get it. I just wanted to show you an example. This is a 2-sided sheet that all of our fire rigs and ambulances carry with them. So we carry these community resources with us so that we can hand them out in public. So this is just every one of our 911 providers has some resource to be able to give out to folks. And we have Dane County Human Services look this over, and Public Health look this over, so that we understand that we're giving, pertinent, good, up-to-date resources to folks when we visit them. Another thing that we've been able to do is work directly with hospitals. So with Meriter Hospital here in Madison, We started a partnership with them in 2018 where we were directly case managing or helping to case manage 10 of their frequent utilizers of the Meritor's emergency room. So 10 patients at a time. And the Meritor Foundation gave us $50,000 as a pilot program to work directly with Meritor. And over 8 months' time, we did a study on total cost of healthcare savings. And for the 10 patients that we saw over 8 months, we were able to save over $500,000 in total cost of healthcare because of the utilization of services being a lot more appropriate with people going where they needed to be. So we now receive money every year from Meritor to continuously case manage at least 10 of their patients out in the community. So basically what that means is we meet with Meritor's nurse case managers and ER doctors and social workers, and they give us direction on what we need to do when we go out and meet folks in the community. The third thing that we do besides crisis response is we work with the Madison Police Department on an addiction resource team. They received a federal grant, a 3-year federal grant called Pathways to Recovery, which is really designed around helping folks that have had opioid addiction issues avoid jail and get into treatment. And we send a community paramedic out with this team as well to help address any medical issues that they might be having. But this is really all about helping divert clients from jail and getting them to the treatment for substance abuse issues that they need. So that's just kind of the foundation of how the fire department gets kind of involved in these sort of programs. It's all about community risk reduction, right? So, for decades, we've done a lot around fire prevention, right? We have strong fire code enforcement rules and, smoke detector ordinances and sprinkler ordinances. And we do a lot around fire safety and fire protection and fire prevention. But now what we're really trying to do is work on some other things in the community risk reduction area. And crisis response is our most recent program that started last September. So we started September of 2021. And basically, like I mentioned earlier, and in most cities around the country, the mental health crisis response model is very law enforcement driven, right? If the 911 center gets a call for fire, it goes to the fire department. If it gets a call for a medical problem, it goes to the paramedics. But everything else was pretty much taken by the police department. And in 2019, the Madison Police Department estimates they received around 7,000 calls related to mental health crisis. So when we looked around the country at best practices and, like it was already mentioned, the CAHOOTS program out in Eugene, Oregon, the STAR program in Denver, San Francisco has a good street crisis response program that sends non-law enforcement personnel out to behavioral health crisis. And those are really the most patient-centered types of models when you talk about the fact that no matter how well-trained police officers are, when folks are in a behavioral health crisis, it's just hard for them to see somebody walking through the door with a badge and a gun on their hip. And so that can be very escalating for people, regardless of how well trained the police officer is. And so we found that that when the mayor's office asked us to look into these programs, we really found that sending a community paramedic and a crisis worker was going to be the best model to respond to nonviolent mental health crisis. So I say nonviolent because that's obviously the key to this. The 911 center, when they get these 911 calls, they have to ask some safety questions. If there's a weapon involved or somebody's behavior is very threatening to somebody else, law enforcement still has to go. But as you're going to see in some slides that I'm going to show with some data, there's a large range of behavioral health crisis calls where no violence is really involved and law enforcement really isn't needed. So when you can send a paramedic and a crisis worker at the right time and the right place to provide the right intervention right away at the beginning of a 911 call, it certainly increases the patient satisfaction and their outcomes. And it helps to divert folks from emergency rooms if they don't need to be there, and can even help divert folks from jail as well. So our alternative intervention, like I mentioned, was a community paramedic and a trained crisis worker. And I just want to say before I go on, the crisis workers that we use on our team come from Journey Mental Health, and I'll explain why that is in a second. But here's just a brief timeline of how things kind of went. So in summer of 2020, we had one of our alders, Arvina Martin, approach the fire chief to talk about developing a crisis response team out of the fire department. The city council was very agreeable and supported us, and so they approved some initial funding. We started hiring folks. We hired 2 more community paramedics and 2 journey crisis workers in the spring of 21. In June of 2021, we had everybody hired and we were providing them extra training. So the community paramedics didn't have any foundational training in crisis response. So we sent them to the NAMI 40-hour crisis intervention training course. We gave them some extra de-escalation and scene safety training through the police department. And then the crisis workers needed to have some kind of 911 system training. So how to use radios. And they also needed more kind of scene safety, you know, what it's like to be in people's homes and stay safe. And then September 1st of 2021, we put the first CARES team in service. So we had 1 team responding Monday through Friday from 11 a.m. to 7 p.m. So we were only running 8 hours a day, Monday through Friday initially. And that was kind of what the budget allowed us to do. And we wanted to start small, kind of phase the project in. So we made sure that what we were doing was, you know, was appropriate and we could evaluate things as we were going before we decided to expand. And so July of this year, we put a second CARES team in service. And I just want to go through some data with you about kind of what the Madison Police Department found from 2 years worth of data. So the charts I'm going to show you here are Madison Police Department mental health related data from 2018 to 2020. So the bar on the left here shows their regular calls for service or other calls besides mental health related calls take about 60 minutes. And their mental health related calls were taking about 3 hours. So this was, you know, a lot of extra time being spent by police officers for things that maybe could have been handled by another team and let that law enforcement officer do their job, which is enforcing the law. So we definitely saw that we could hopefully reduce some operational stress from the police department and provide a good service. And this slide here shows what happened on those mental health related calls. So arrests were only about 5%, citations were 2%, and emergency detentions were at 2%. So we saw this really big opportunity to address these folks without law enforcement needed. And when we looked at where the police department was busiest with mental health related calls, out of the 6 police districts in the city of Madison, the central district, as you might expect, was the busiest, right? So that's the downtown and Isthmus area. By square mile, they by far had the most mental health related calls for service. And then when we look at the time of day, this heat map across the top shows all 24 hours. You can see from about 10 a.m. to about 8 or 9 p.m. was actually the busiest time of the day for mental health related calls. And surprisingly to me, Monday through Friday were actually the busiest days for mental health related calls. I would have guessed that the weekends would have been heavier because I can remember working as a paramedic dealing with what I consider to be more probably alcohol abuse and maybe drug abuse on the weekends, but for just standard kind of general behavioral health calls, Monday through Friday really was a busier time. So when we chose to run our pilot program, we were working the Central District Monday through Friday from 11 a.m. to 8 p.m. I'm sorry, to 7 p.m. to make it an 8-hour day and a 40-hour week. So I want to talk about some partnerships. I mentioned Journey Mental Health is who we worked with, is who we do work with as our crisis responders. But we actually had to sign a contract with Dane County Human Services. And the reasons for that is that in the state of Wisconsin, there is an administrative rule, a statute, it's DHS 34 that outlines that every county in the state of Wisconsin has a statutory authority to oversee mobile crisis response teams. So Dane County Human Services oversees our program, and we pay them the money so that they can pay Journey Mental Health because they contract with Journey Mental Health for services, for crisis response services in Dane County. So we have a contract with Dane County who pays Journey Mental Health to work with us. And then the other big partner, of course, is the Dane County 911 Center. They're the ones that are responsible for triaging these calls to the appropriate resource, right? Like I mentioned earlier, it's either going to be police, fire, or EMS traditionally, but now they have this 4th resource, which is the crisis response team or CARES team. And again, it's their job to make sure that they're sending the right folks to the right call at the right time. And they've been great with actually triaging those calls appropriately. And I'll show some data at the end here that shows, kind of how often police have had to respond after CARES has responded. And it's been a very small amount. So that means the 911 center is doing a good job of sending the right folks to the right calls. So our operations, just to kind of an overview of what we do and how we operate. So the team that responds is one Journey crisis worker and one Madison Fire Department community paramedic. And they respond in a fire department SUV. So it does have lights and sirens, but they use them minimally, only when needed. They are in operation right now because we have two teams from 8 a.m. to 8 p.m. Monday through Friday. So we have one team that works from 8 to 5 and one team that works from 11 to 8. So they have that crossover in the middle of the day. That really busiest part of the day is that kind of 11 to 5. And so we have two teams running at that time. And they respond anywhere in the city of Madison now. Like I said, we started in that central district. And once we started to realize we had capacity to take on more calls, we expanded citywide. And just some of the tools and supplies that they carry, because there's paramedics. An ALS medical bag just means it's advanced life support. So they have the capability of providing a lot of good emergency medical services on scene. And if they ever do need to do things like start IVs or give medications, they'll be calling in an ambulance to assist them and transport the patient. They carry a cooler with water and snacks for folks that might need that. Medication lock boxes. These lock boxes are so that we can hand out to people so that they can keep their medications safe. Some folks have trouble with maybe family members or friends getting into their medications, or kids. So we give them a way of keeping their medication safe. We have sharps containers. We hand out Narcan to folks that believe they or their friends or family might need it. Fentanyl test strips are an important one. That's a big public health push right now, so people can test the substances they're using for fentanyl before they use them. We have a breathalyzer because we do transport people to detox if needed. If people are voluntary and want to go to detox, we can actually transport them instead of law enforcement. And historically, only police officers have been able to transport people to detox because of the protective custody order. But now we can transport them, and then the nurse at detox can write the protective custody order. So that breathalyzer helps us just give the detox nurse an idea of how the patient is doing. And then, vomit bags, flashlights, safety vests, fire extinguisher, kind of the typical stuff you would expect of a street crisis response team. And dispositions, in other words, what can we do with people? If we're not able to resolve a situation on scene with someone, we have the ability to transport them wherever it is they need to be transported. So if their home is where their support system is, and that's really where they need to be, we can take them home. Madison Fire Department ambulances can only transport to emergency rooms by state statute and by our operational plan. Our ambulances can't even take somebody to an urgent care, but our crisis response team can take folks wherever they want to because we don't charge for the service. So whether it's a detox or a shelter or somebody's home or a community resource that they need, we're able to kind of assist with any of that stuff. And really the main thing is that we want to connect people to services. And it's not just Journey mental health services, it's any services in the community that is appropriate for that patient. And so this is just another example, kind of a non-exhaustive list here on the right of some of the services that we transport folks to and work in conjunction with to help with those case management issues. And so we have a data dashboard that Public Health has put together for us. It's receiving data from the Journey Mental Health EHR, so from their patient health record, and then it receives information from the Madison Fire Department community paramedic patient care report, and it also gets information from the 911 center and kind of brings it into this nice interactive data dashboard. So I'm just going to go through a few screenshots here. This date ranges from September 2nd of 21 to August 30th of 22. So the data is, these shots are over a month old. We've been on over 1,000 calls now, but you can see that we have a total number of responses here. At the time was 935, but a lot of these folks we see more than once. So we've seen at this time, we had seen 558 individuals. Yeah. And you can see over time, the call volume has certainly picked up when we added that second team. And when we started responding citywide, we were able to increase the call volume of the teams by month. We capture whether people have been seen by Journey Mental Health before or been seen by CARES before. And the good thing about Journey is that they've been in the Madison area so long, they have a great history on folks. And so when they bring their laptops on these calls and they can put in somebody's name and birth date and bring up their history and their case management notes and what's been going on with them, it allows them to provide better services. So Journey has been a good partner in that regard. The next page, of course, is demographics. It's important for us to understand who we're serving. And I get a lot of questions from the city council and the mayor's office and a lot of other folks about demographics of people. So you can see we've got, the ages listed, race, ethnicity, sex, gender identity, language, veteran status, and whether or not people are experiencing homelessness. This is more incident related, again, kind of the number of responses. It takes us about an hour for each one of these calls on average. So it's a time consuming endeavor to go help people that are having behavioral health crisis. And that's okay. We want our providers to spend as much time with folks as possible. And then refer them to services. But you can see the 6 different police districts, calls during the day of the week, the call types, calls per time of day, and then a heat map that you can actually interact with and zoom in and zoom out, and you can see where the most calls are happening. And this is kind of the medical side of things, the primary impression of the paramedic, the primary complaint of the patient. The primary diagnosis comes from the Journey mental health record, right? Paramedics don't diagnose mental health disorders, but that's part of Journey's job. Co-occurring substance abuse, again, whether they're insured or not, and kind of where the call originated from. And then the last page is the outcome, what ends up happening with folks. And so about 14% of the over 1,000 calls that we've gone on now are actually handled by phone contact only. There's a lot of folks out there that really just want to talk to somebody. Maybe it's a family member that wants to talk about resources for one of their children that are having difficulties. Whatever it is, there are some folks that just want a phone contact. Some people refuse evaluation. So a lot of these folks are when somebody else calls 911 because they think somebody's having a behavioral health crisis, we get on scene and that person says, nope, I don't want to talk to you. I'm just fine. And this is a voluntary thing for them, right? We're not forcing our services on them. So we have some people refuse. About 34% of folks get treated and have an intervention on scene and don't need transport anywhere. And they're happy with that, and they are either maybe given some resources to follow up on, and then we call them a few days later. We like to do follow-up phone calls for folks to see if the services they received that day were appropriate for them and how things are going. We have about 1% are treated and released against medical advice. So this means our paramedics said, hey, you have a medical condition that we think you need to be transported to the hospital for. And they say, nope, I don't want to go. And so we, again, can't kidnap them. So they sign a form saying that they don't want to be treated, and that's okay. The 3% here is treated and transported by paramedics. So that means they had a medical condition that needed attention by a paramedic ambulance in an emergency room. And then this almost 30% here is treated and transported somewhere in the community for services. And so these are the ones that we really like to have, where we can provide a warm handoff to a provider in the community and make sure that this person is taken to where they want to go and to where they need to go. And this is important here, this 3% taken by law enforcement. That means that our CARES team initially responded, but for one reason or another, they had to call law enforcement in. It doesn't mean it was for an arrest, but it means it was likely for some sort of protective custody or emergency detention due to the patient, being suicidal with a plan, things like that. Sometimes law enforcement does still need to be involved, but out of those 1,000 calls, for 3% of them to end up in police hands, that's a good number for us. That means that we really are diverting quite a few folks from law enforcement. And then this last 5% here not reported, that's the data that is a glitch somewhere. So we've got work to do on this. So this whole data dashboard isn't public facing yet. It's still internal facing. We're working on some glitches. But public health has been really, really good for us because I'm not a data guy and I couldn't have put this together myself. So I always want to give thanks to Madison Dane County Public Health for giving us their resources and helping us out with this stuff. And so this is just a picture of our CARES team, the 2 Madison Fire Department paramedics and the Journey crisis workers. We now have 4 crisis workers and 4 paramedics. And in the mayor's executive budget for 2023, we're going to hire 1 more of each so that we can open up weekend hours. So hopefully in the first quarter of 2023, we will have 7-day-a-week, 8 a.m. to 8 p.m. services. And then the vision downstream will eventually, hopefully, be 24/7 coverage around the city. And boy, you know, within hopefully 4 to 5 years, this will be a whole Dane County program, and there will be multiple fire departments involved in this. And you know, as long as things keep going well, I don't see why this program won't continue to expand. And that is my presentation. I drank a lot of coffee this morning, so I talk super fast, but I'm happy to answer questions.
No, I was curious right away about, you know, if I'm Sun Prairie or Oregon or Fitchburg, am I paying attention to this? And of course, they're in the county, and maybe a little jealous that you know, but you guys are paying for it to the county. So if they stepped up, is that right?
Yeah. The city of Madison is paying for these services right now. We pay for the Journey crisis workers' salary and benefits, and of course the community paramedics' salaries and benefits. And then there's also a lot of equipment, vehicles, and all of the other accoutrements that come along with putting an emergency services team on the street. So it's expensive, unfortunately. But there's another model that's called a co-responder model that utilizes law enforcement and crisis workers. And so like the University of Wisconsin Police Department is doing that. I know Sun Prairie PD is looking at doing that. And that's a good model as well. It just still, you know, for some folks, having that law enforcement person on scene can still be a little escalating, but in some cases, it's more cost effective to pair a police officer with a crisis worker. So again, these are just, you know, every city has a different model that's going to work for them. And Madison thought that this model was going to work best for us. And hopefully, you know, the county will see that as well. But honestly, I believe that as long as you have a crisis worker responding in some way, shape, or form to that initial behavioral health emergency, I think that's really important. Whether you use a police officer or a paramedic, I think is really a community need type thing, and it's resources. You know, a lot of communities don't have career firefighters and career paramedics. A lot of them are volunteer, and so you can't ask people to volunteer their time, right, to do this stuff. So it really does come down to budget and what your city needs.
Well, and liability, of course, you know, for volunteers, that would be a nightmare for anything to do it. So, you know, is this all new money in the Madison budget? And of course, the reason I ask is because the whole defund the police issue is actually a broader question about how do we spend our money on public health? And so the question is, is this a carve out from the police? Is it a carve out from what you were doing? Is it new public health money?
Yes. So I can answer that question very specifically. The initial $550,000 was to put that one team on the street annually. And they after 3 months, the council saw pretty quickly that this team was you know, doing good work. The services were effective. So they made a budget amendment to add more crisis workers. And in that amendment, it was $250,000 that unfortunately, in my mind, did come from the police department. It took 4 recruit spots from our police department. And that was a little hard for me, to be honest. You know, our sister department, we work very closely. I didn't want to be the fire guy being seen as taking money from the police department. Right. But that did happen. But moving forward, I don't believe any other monies has come from the police department. And you know, I see it on one hand, we are reducing some stress from the police department. The police officers like having us on the street so that they don't have to go to those calls, so that they can free up their time to enforce the law somewhere else. But yeah, it's a very delicate balance, in my opinion, about what you take from a police department for these services. It's hard for me to speak to because I don't like taking money from the police department.
Yeah.
Let me ask a related question, Terry and Che.
Yeah.
I remember in the 80s and 90s when I was teaching graduate students, and we were dealing with a whole move towards deinstitutionalization. And it was really seen as a very positive, more humane way of dealing with people instead of tossing them into an institution, not necessarily correctional, but an institution. And I had a couple of students who were actually on the staff of the fire department. And they pointed out that as a result of that, what they were seeing was people who needed to be on their medications, but were not good about staying on their medications, were kind of weekly cases for the fire department that, they just knew that Joe Schmo was going to need his meds and he was going to be acting out. And one of the issues that we were dealing with, and I'm impressed by the evidence-based kind of position that you're in now, because there wasn't much evidence there. It was more intuitive and anecdotal, was, okay, so we're saying that we're saving a lot of money with deinstitutionalization, but actually all we're doing is shifting the costs to the fire department, because these people probably ought to be institutionalized and certainly need ongoing care. We're getting care by the fire department and probably not the best way.
Yeah, and that's a good point, and that's why we started our community paramedic programming back in 2016, was because we recognized that we could very inexpensively go out and address these issues with folks. And I mentioned earlier, medication reconciliation, looking at their discharge paperwork from an ER visit that they recently went to, or looking at what they were supposed to be doing, and maybe they had multiple medications from different doctors that were interacting with each other in the wrong way. And so just those little simple fixes in people's homes saves a lot on the back end. And again, we weren't charging for these services because it's part of our service to the community, right? It's community risk reduction. It helps reduce unneeded 911 calls, and it's been a very a successful program for us, luckily. And unfortunately, we just don't have enough of them, right? I could use 10 more community paramedics in my budget right now, and they'd be out there doing great work, but we can only afford so many. But yeah, it's needed work. And you're exactly right about your point that we get a lot of calls for 911 that shouldn't be.
So if someone, you said earlier, Che, that people just want to talk. So that means someone's actually, there's not a different number. It's people will make that 911 call, and it's not that mental health number about.
Right. Yeah. So they're not calling, they could call the Journey crisis line, but they just didn't know the number. Right. Now we have 988, but that's a new thing. And probably a lot of folks don't know about it. So 911 does tend to be the catch-all. And there are certainly a lot of folks that call that they really just sometimes need questions answered, and they don't actually need to see a person face to face. And so that's been something that is new in our 911 system, is that, boy, we can really help these folks out without actually disturbing them and knocking on their door or anything else. And it's been one really kind of enlightening thing for us to see that other cities are using very successfully is mental health triage folks working in their 911 centers. So that, so they actually have like a crisis triage person working in the 911 center that can talk people through these things. And I know Dane County 911 is looking into this model, but again, it costs money, right? To hire, because you have to hire numerous mental health professionals to work in the 911 center to cover 24/7.
It's interesting to me how innovative and creative and obviously successful this is. Yet I know there were probably people who say that, they're worried about crime or whatever. And it reminds me a little bit about, when Dennis, who was the mayor in New York, gave away the needle exchanges back in the 90s or 80s. And it's just like now with, they've got vending machines in New York for clean needles. New York's got this place where you can actually do a drug injection site, supervised injection site. All of it, which seems to me to be like, there are different ways to approach public health. If you don't just do the knee-jerk reaction of we just need more cops or how can they possibly give away new needles or fentanyl strips? What's that all about? I mean, does these kind of ideas take a while for people just to understand what the long-term advantage is in doing some of this?
Yeah, so certainly. And you know, what I do is I listen to public health officials, and I listen to the UW hospital, because that's where we get our medical direction from. And when they talk to us about certain issues in the community and they say, here's what we would like to do about it, we follow suit, really, as the fire department. And I don't mean to downplay, you know, our decision making, but those are the folks we need to listen to address what's really going on in the community. If we cocoon ourselves, right, and silo ourselves, and we just say, nope, we're just going to fire calls and heart attacks and car accidents, and don't do any of this other stuff that really has a good effect on the community, we're not doing our job. There's a reasonable expectation that we're going to address the most important things going on in the community. And so when public health tells us, hey, there's a bunch of fentanyl out there in the community that is being laced into other things that people don't know about, and if you can give them this tool to save their life, like that's common sense to us. And sure, there's people hated it when we were giving out Narcan to folks, right? They're like, well, you're giving them Narcan, you're giving them a free pass to do heroin. And I personally don't see it that way, but my directive is to try to save lives and to try to prevent these things from happening. So it's a pretty easy decision for the fire department to make.
Could I ask you to go back to one of your slides to show the people who you serve, gender, age, race?
Yes.
I'm curious in that, and also the heat map of where you've gone, and for a couple of reasons. So when Dennis and I and Kurt at La Follette, we did a thing on youth violence as a public policy, as a public health issue, gangs and youth violence and public health, public policy and public health. One of the things we found out, I think, Dennis, you recall, that it wasn't just all African Americans in Central City. And I remember we went down with Vice President Al Gore's in Tennessee at that program where you presented, Dennis, about your studies over the 20 years, that there was pushback because we found out there were actually problems in some really nice neighborhoods. And people didn't want to see extra cops and other things, but couldn't believe that, you mean, what do we don't have that kind of thing in our neighborhoods. And so I'm curious, two things. One, that heat map to show exactly where, and also this one. I really want to look at this one. So it's not just all old people.
Yeah, and you know, 65 plus is a big age range. You know, when I've showed this to other groups, they've said, well, boy, that's kind of a big population of older people. But you got to realize that these are all pretty small chunks of age groups, and then 65 plus is a lot. So, and you know, honestly, we go on check welfare calls. Like just somebody calls and says, hey, I haven't talked to my grandma in 3 days. I live in Minneapolis. Can you please go check on her? Like we'll take that call.
Wow.
Because that's a call that the police normally would have taken. And if when we get there, if grandma's really sick, we can have the paramedics start treating her, or if grandma's having an issue with her dementia or something else, we can get her the right resources. So yeah, I mean, we do see a pretty broad range of ages. We really don't, you know, deal a lot with juveniles, but you know, we will see them. You know, I saw a message in the chat asking if we responded to the UW campus, and we do. They're part of our jurisdiction, and whenever we find a student that we have a call for service for, we know to refer them to UW mental health services, right? We need to know what services are available to those folks, and so we actually work pretty closely with UHS on the mental health side.
So most are not homeless.
Yeah, about 13%.
Yeah. Okay.
Are homeless, I should say.
Yeah.
And 10% not reported. That could go either way. So this is a plus or minus, right? It's really hard to have accurate data when you're dealing with you know, behavioral health crisis, because some folks don't want to, they don't want to tell you the full story. You know, we can only gather what they'll tell us, and so I have a hard time, you know, really looking at this data and saying that this is a, you know, for sure, exactly accurate point of data.
And about half men and women. Again, I see your plus or minus, but
yeah,
it's interesting. I guess in my head, I've got the stereotype of like that picture you showed, somebody sitting under, at a wall under a railroad trestle or something, homeless and, like that. But it seems like it's men and women, and they're not necessarily homeless, and
Yeah.
60% white. Okay.
Yeah, and so when you look at the race ethnicity, I think this is in my opinion, this is a general representation of the population of Madison, right?
Right.
Yeah, this is I think we seem to be serving our population equally, but with 911, you're serving who calls. And I can tell you right now that there are a lot of Hmong folks that don't like calling 911 just because of how stoic they are. If you're a non-English speaking Spanish person, right, you're Hispanic and you don't speak English, you might not be as inclined to use 911 services. So I think there are still race and ethnicity barriers to 911 in general, but we serve who calls.
Yeah, and
I'm curious about the identification of veterans as a separate category. Is it PTSD driven, or why a special?
Yeah, we like to know this because obviously Madison has our VA here, and we like folks to be able to utilize the VA when it's appropriate for them. So we do typically ask that question, and it really does give our providers a little bit more insight into possibly might be going on with the person. So that is a common question that we try to ask.
And I think, Dennis, last I saw, I think we are about 12% African American. So 14 would be right about that.
Right.
Does Milwaukee have anything like this, Che?
So Milwaukee has some crisis response services, but they're run out of the hospitals. They're not run through Milwaukee Fire. And so Milwaukee Fire does have community paramedics, but they aren't working in crisis right now. But they do have mobile crisis response in Milwaukee that integrates what I believe that integrates. I know for sure, obviously, a crisis worker, but and I believe it's an EMT or some other medical provider, but it comes through the hospitals, not the fire department.
Your program's relatively new. Is this ramped quickly? I mean, are you growing the number of issues you're going out for?
Like the call types that we're responding to, or
no, the volume. I was thinking.
Yeah, the volume is definitely expanding. Yeah, you can see here this chart starts, September of 21 when we started. Yeah, and it just has slowly grown. The 911 center started out, erring on the side of safety. So we were only going on 2 to 3 calls a day in the very beginning because we wanted to make sure that we were putting our folks in a position to succeed and that it wasn't dangerous. And I'll give you a quick example. A common question that a 911 call taker will say is like, do you have a weapon on you? And, most homeless folks have a pocket knife. And so if that person said, yeah, I have a pocket knife, in the very beginning, they wouldn't even send us to that. And we have conversations. We meet every 2 weeks with the 911 center to talk about all this stuff. And our providers were saying, hey, if a homeless person has a pocket knife, that's normal. What matters is their intent and their behavior at the time. Like, we're comfortable going as long as that person's not threatening people's lives. And so those are the little learning things that we've had that have increased our call volume. You start being safe, but then over time, you got to start taking incremental risks as long as they're worth it.
Have any of your teams been hurt, injured?
No, and fortunately, no. We the worst incident so far has been that somebody jumped out of the vehicle, out of the window, but luckily the driver was able to pull over, so the vehicle was almost stopped completely when the person had jumped out. We were taking them to a provider, and they got nervous and anxious and just didn't want to go anymore. And they actually had their boyfriend in the car, or their girlfriend in the car, but they decided to jump out of the car. And the person didn't get hurt at all, but that was still scary for us. And so I had to remind our folks that we have police interceptors that have door locks and window locks, but they just weren't used to having to use them. So now they make sure that they use the door and window locks for everybody regardless. So that was the only kind of, misstep or scary situation we've had so far.
That is really interesting that as you mentioned before, they're doing such a good job at screening. The kind of careers that you never hear about, the kind of things that happen with 911, except at crisis, gun, school shootings, you want to hear that voice and what happened, but they're kind of just normal every day to day. Just like you growing up to be a firefighter, you didn't think you'd be doing
right
this kind of thing. So the heat map, I want to look at a minute for. So
And there was one more question too about treat and release. Somebody
Yep.
asked about treat and release, and what does that consist of?
Boy, that's any number of things. So that means that the crisis worker and or the paramedic were able to provide an intervention on scene that was beneficial enough to the person that they didn't need to go anywhere. You know, some of these calls are for what you all might consider lower level behavioral health crisis, right? And so somebody that just needs to talk to somebody, they need an answer about where to go next. They need to talk through something. I mean, these calls are all so unique. It's hard to generalize, but that's all of these folks don't need to go somewhere. They just need something done for them, something given to them, possibly like, hey, here's where you should go for this, right? Like here's where you can get these resources from, or here's the application for Badger Care, whatever it is. That's just how these calls have turned out. It's hard to give a general answer to that one.
Yeah, but you can see all the things that you carry with you
Yeah.
from you've experienced now. What would be helpful, like candy bar, you know, water, stuff like
Yeah.
that.
And we're fortunate, we've got a community paramedic foundation, you know, a nonprofit that we can take, you know, anytime somebody donates money to the fire department for any reason, it goes into this community paramedic foundation. So we can buy people clothing. We've bought air conditioners for folks, you know, furniture, whatever it is that they truly need. We've luckily got a slush fund to utilize for those folks.
Wow. So people can find that to donate how?
Well, you can ask me. Basically, if somebody sends, like we have folks that are appreciative for services, so they'll send money to the fire department, and we can't cash a check as a Madison Fire Department, right? So then we ask them, we say, hey, you know, we can't accept this, but we do have a foundation that helps people in need. If you don't mind donating to that. I honestly don't think there's a website for it or anything else. It's just
new message.
Never knew that at all. Wow.
Yeah, interesting.
For some reason, Kurt and Dennis, my chat is not showing up. So if you see something, but
Yeah,
I want to ask.
There was just one more question, I think, in the chat anyway. You can probably read that, Che, yourself. It's a little bit longer.
Okay, I'm gonna have to stop sharing my screen.
Oh no, okay.
wait.
Otherwise, I can read it too.
Go ahead. Sorry.
Read it.
It's hard to convince law enforcement well, basically they're asking, are there beds available in Dane County for, let's see,
A repeat.
for repeats?
For repeats, for what services?
For just I'm not certain. I don't think.
Yes. So I mean, I can speak that there's oftentimes no beds at detox available. There's oftentimes, you know, Meritor has a floor where we can take, you know, mental health related issues where they treat people. Sometimes they don't have beds. So bed availability is always a concern for us. And, you know, resources in the community, one of the, you know, reasons that we work, you know, from 8 a.m. to 8 p.m. really, it's a busier time, but also that's when the services are open. You know, if we were to respond at 2 a.m. for a behavioral health crisis, it would be hard to find a resource other than a hospital to take that person to. And so that's, you know, Dane County right now has, I believe, $10 million or so in their budget to build a mental health triage center. And that's supposed to happen in the coming years. So there'll be a good brick and mortar facility that's open 24/7 for us to take folks to. And that's going to be a game changer for us. You know, right now, as most of you probably know, if a police officer puts somebody in protective custody because of behavioral health stuff, protective custody means that person's probably going to Winnebago, and that's far away, and it takes up time and resources. And so Dane County will hopefully have that sort of resource right here in the county for us.
That's an amazing. I just didn't know there was such a lack of some of these kind of things. This is really pretty incredible, but it's great to hear how it's being addressed. On the heat map, so you said you started central and now, and that's still 37%. Okay.
Yeah. And so for the first 3 months, we were only responding in the central district. So I would imagine over time, these will even out a little bit, but I think the central district will always be the busiest. I mean, you saw that in the one data point I showed.
Mhm. Yeah, so that'll skew it right now a little bit, but no. That is really interesting when you see how spread out this is and why you would want to have a county program on this
Yeah,
ultimately.
definitely.
Wow. The data is fascinating to me that, and I know there's probably good La Follette students out there, Dennis, who could have a career. You guys must be hiring some good public policy analysts to do this, or the county is.
Yeah. Yeah, and this is through public health. This platform is called Power BI, and public health uses this for like their COVID data page, and they've got obviously a lot of really good data analysts and evaluators that are invaluable for us.
Yeah, the evidence-based stuff, Dennis, is just, I mean, it's just mind-boggling to see what's changed over, even the 20 years I was, 25 years I was.
Oh, yeah. Yeah, very much so.
One little fact for you there, Che, that Arvina Martin is the daughter of Karen Martin, who was one of Dennis's and our students at La Follette.
Oh.
And so Arvina is, we know Arvina very well, know her mom, and her dad was Buck, who's already died. But it's great to see her being involved in this. And I think Dennis, from Karen's perspective, from the public policy perspective, is fascinating to see how this circle goes for paying attention to these things.
Yeah, she really did start it, and I miss her as an alder.
Yeah, and I take credit for all of the good things she's done.
I'll put your name, Dennis. I'll put your name in my slides from now on.
Okay.
So what are the chances of Meritor? Do they have the money to expand beyond those 10? That 10 is really fascinating to me.
Yeah, that's a good question. So they give us, I think all this is, public record, so I'll say it, but they give us $70,000 a year to case manage 10 patients at a time. And the healthcare system is saving, like I mentioned, quite a bit more than that. But that 70,000, that helps us pay for salaries of at least one community paramedic, and we're happy with this relationship right now. But yeah, they haven't approached us and said, hey, we'd like to double the efforts here. We're just happy to have them as a partner. We're working before COVID hit. We were talking with the UW hospital system about doing something similar, and that kind of fell off the radar during COVID, and now UW and Meritor are kind of married together. That whole thing confuses me, but yeah, I mean, if we had a bigger budget to hire more community paramedics, they would be busy, no doubt. There's more work than we have people for.
Yeah.
There's Susan put in a comment in the chat line about the facility in Middleton. I guess it's sort of being built.
Well, Marymount, I think, is what.
Yeah, it raises the question. My understanding is that when it comes to the fire department working with, if the fire department has a crisis and it's outside the jurisdiction, there's an agreement among the fire departments in the community generally to help out.
Yes.
Does that apply to these mental health services too?
So the CARES services are only available in the city of Madison right now. So we won't go into any of our surrounding communities for crisis response. And the agreement that you're talking about is it's an ALS agreement, so advanced life support. So basically, if the Middleton paramedics are busy on calls, they have 2 ambulances. If both of their ambulances are on calls and another heart attack comes in Middleton, city of Madison will send a paramedic unit out there. They send the closest paramedic unit to whatever call is going on in the county. And that's important for those, high level true emergencies. But that's only on the significant call side. For crisis response, we are only responding in the city of Madison, but we also, now we have the town of Madison, we cover Shorewood, we cover Burke for EMS, so we do have some other communities that we respond into by contract. But we do take people to that. Marymount is open. They've been open for a little while now, and we do take people out to there. They're a for-profit mental health provider, but they've agreed to open beds up for our team. And so we do transport people out there, but we contact them first and ask them if they have beds available, like we typically do. So we have a good relationship with Marymount. They've been a good partner for a for-profit business. They've been good about working with us.
You know, I remember again when I was a city reporter up in La Crosse, that the fire department would come in and ask for, you know, new hoses or a place to dry the hoses or whatever. And the council would always give them money right away. Police would come in and ask for something. Well, everybody has had a bad experience with a police officer. You know, all the council members like, well, I don't know, but fire comes in, you guys are always rescuing, you're always doing good stuff. And so this just reinforces to me why they would always be willing to give the fire department more money.
Well, I will say we don't get everything we want. But I do appreciate the fact that the community tends to have trust in us, and you know that we're looked upon as an organization that needs to be providing service. So yeah, we're fortunate. You know, just the Madison Fire Department in general has always been well supported, and you know, I hope when I talk about our budget limitations, I'm not complaining, right? I'm just that's the fact of the world we live in. But
well, the opportunities for solving a lot of problems with it. So I don't know that my grandson, who was up at the Sun Prairie Fire Department open house yesterday, he came back with a hat, but I don't think he said he wanted to be a behavioral crisis,
yeah, right.
behavioral health crisis worker. Still wants the fire hat and still wants the red engine.
Yep, and that's understandable.
Dennis, I can't see chat. Are there other questions and things?
That was most of them.
Or is there any more that people want to look at of things? I know we've taken an hour of your time. It's been fantastic.
It's been very good.
This is amazing. Yeah.
Well, thanks. And I guess we're going to wrap it up. Dennis, I'll let you do it. I just want to say thanks, Jay, but I'll let you do it. Dennis.
Yeah, thank you very much. We really appreciate it. Nice to know about this is a resource, and it's a real gem in our community. So thank you very much for the explanation as well as your service.
Yeah. Hit me up in 6 months or a year, and I'll give you an update.
And I'm gonna also, Shay, do an email with you to find out how people can donate to that foundation, to that, because I think that even after being city editor here for 5-6 years, I never heard of that thing.
Yeah, and we've probably done a bad job of promoting it. And when you talked to me about that earlier, I thought to myself, we need to get something on our website about it. Sure. I'm not a good marketing guy, but you just made me one. So,
well, thank you so much.
Yep, I'm going to put my email in the chat here for everybody.
Good. That would be
great. Thank you.
Oh, now it all showed up. All the chats are now showing up. I did something stupid. All right. Thanks so much.
Yes, thank you.
Thanks.
Thank you.
Bye-bye.
And Kurt, you want to talk about the first half of the program next week, and the second half I'll just mention quickly is
sure.
Our member of Congress, Mark Pocan, will be with us from 11 o'clock onwards a week from today.
And the first part of it will be kind of the future of banking and money, the future banking and the money system. I got a couple of people from In Business Bank are going to come in and talk to us about that. So,
yeah, and that's going to be interesting. I hope whether that's a big topic where, I don't know if they're going to
I don't know if they're going to hit cryptocurrency much or digital currency much, but that obviously is coming. I can fill in parts of that, but.
Well, the whole decentralized financing is going to be a big piece of it, I hope. It reminds me very much of what's happening with sort of the do-it-yourself health things. Because you wonder, now we can get hearing aids. People do their own COVID test at home. They're doing those things. You go away from the orthodontist and just get that Invisalign. You don't have to go to a doctor. So all this, it's like do-it-yourself health, do-it-yourself finance. I don't know what the world's changing, but there's something out there about how all of this is coming together.
Yeah, this one was really good, I thought.
So. All right. Well, thanks everybody.
Yeah.
All right.
Yes, thank you.
All right.
See you next week.
All right. Thanks.
Yep. Bye now.